So the clinical lab plays a central role in patient management, and I must say we are constantly being reminded of the need to ensure the highest possible quality in all lab services. We know that the lab is defined by its ability to deliver reliable and timely results. And errors in any part of the testing process, be it pre-analytical, analytical, or post-analytical phases, can compromise the quality of our results, which in turn affects clinical decision making and may lead to incorrect diagnosis and inappropriate treatment. So we use the International Organization for Standardization Standards, and according to that, the pre-analytical phase begins with the doctor's request, and it includes patient preparation and identification and collection of the specimen, as well as the transport of those specimens to and within the lab. This phase only ends when the analytical step begins. Next slide, please. So several studies have shown that most lab errors arise in the pre-analytical phase, and these account for about 70% of all mistakes. And these areas are largely linked to manual processes. These include discrepancies between patient identification on requisition and specimen forms, no identification on the specimen form or the container, the specimen type also not noted or test not indicated on requisition. They can even be tissue samples, for example, submitted in formalin, or the wrong container, such as a central venous catheter in a specimen bag being submitted, and leaking containers. So those standards that I mentioned requires labs to adopt systems that safeguard patients by minimizing the risk of getting out misleading results when a specimen has been compromised. So for this reason, every specimen is checked before testing, and we assess for we assess for all of these factors before we even begin processing the specimen. So tracking rejection rates and understanding the reasons behind them allows us to intervene through platforms such as this, where education and training and then we are able to improve processes. Next slide, please. So when we look at the data from our own lab recently, the trends remain fairly consistent from month to month. Fluctuations tend to occur only during new staff intake or rotation of junior doctors or other clinicians. If we take May as an example, we had 315 specimen rejections, and that obviously means 315 delayed results, along with additional costs and wasted staff hours. You can move on to the next one. The main causes of rejections were, so the 61%, which was the majority, were because a separate specimen was required. Insufficient sample volumes accounted for 26%, and 9% of the rejections were due to empty specimen containers being received, and 4% were due to leaking specimens. Can move on. When looking more closely at the category requiring a separate specimen, most cases involve tests that need to be sent to different testing sites. TB culture is one example, as well as beta-D-glucan, which is another example. Please move on. So specifically, the reason that the beta-D-glucan test requires a separate specimen is that this specimen can't be shared between departments. For some labs like ours, it is a referral test, And it is a very sensitive assay, and contamination can easily result in false positive when you are sharing or splitting samples between departments or between tests. Yeah. So different labs have different testing facilities, and TB culture requires a biosafety level 3 lab. So for us and for most labs, this means that the specimen must be referred to another testing site. So to avoid rejections and delay, we always send a separate specimen when we advise that you send a separate specimen when requesting TB culture as well. The next slide. So the second most common reason for rejection is insufficient specimen volume. And this usually occurs when too many tests are ordered, but not enough sample is collected. So we see this a lot with CSFs, but on the next slide, there's a specimen that arrived with one yellow tube, as indicated by the lab personnel in the receiving office, and 3 purple top tubes. So the yellow tubes was needed for a UNE, an LFT, and a CRP, which are processed in the same department and in the same site. So those could be processed together and there were no problems. However, the 3 purple tubes were intended for the FBC, the CD4, the HIV viral load, as well as the hepatitis C viral load. Each of these is performed in a different section of the lab, as well as sometimes in a different site altogether. So because only 3 tubes were provided, the hepatitis C viral load couldn't be performed, resulting in delays. So the next issue is one that involves specimen containers. Some arrive leaking, others arrive completely empty, and this area could be completely be prevented by taking more care in terms of when you're requesting and making sure that before you send to the lab, it actually has been, the sample has been collected, or like on the next slide, Jeremy. When capping containers, a small step like ensuring that the universal container is capped could prevent about 10% of, or over 10% of rejections. Next slide. So if we estimate that, just for argument's sake, each rejection between the laboratory receiving office and the clinical side of things takes up around 30 minutes to resolve, including both repeating the sample and sending out communication that it was rejected. Then in May alone, we wasted about 165 hours. So just to check, if you want, you can type in the chat. If you personally got back an extra 165 hours a month, what would you do with it? So when I said and thought about it, I thought I would like to do some of these things with that 165 hours a month. Financial impact it is also a reality. And in May, the 315 rejections cost an estimated 35,000 Rand. And if we were to, for argument's sake, reduce this number by half, we'd save approximately 18,000 Rand a month, or more than 200,000 per year. Yeah, so this is just saying that for the May data, the 315 specimens or tests that were rejected, we had 36,000 additional costs and 165 hours wasted. So in terms of the hidden costs, the true impact really lies with the patients. Every rejection means repeated collections, which is inconvenient, uncomfortable, and sometimes distressing. It also means delayed results and postponed clinical decisions. I have often spoken to clinicians who are sitting in front of their patient waiting for results, only to discover the specimen was rejected. It's frustrating for the clinician, but I can imagine how distressing it is for the patients. Next slide. In some cases, delays can significantly alter patient outcomes. For example, if we take this example where beta-D-glucan was submitted on day 3, it was eventually discovered that the beta-D-glucan was insufficient, and doctor was contacted to request for another sample. A new specimen was eventually collected on day 4, and results were eventually done. The test was eventually done and resulted 7 days later. And if we use the hepatitis C example that I used before, this can even be longer. And repeat results can be available as long as 45 days later. So the good news is that many of these rejections are predictable and preventable. And for collection team, there's just things that they can do immediately, like double check specimen labels before sealing, verify that the specimen volume matches the order test, and unit heads can track rejection data regularly to identify trends and intervene early. I'm sure we all have the same goal, that for every a patient who gets results faster is a clinician who can make timely decisions. So let's consider the analytical phase. We know the phrase too well, that garbage in, garbage out. And if we start with the poor quality specimen, the results will be unreliable, no matter how good the testing is. And in microbiology, interpretation plays a big role, which makes the quality of the pre-analytical phase even more critical. Proper selection, collection, and transport of specimens optimize analysis and interpretations. So, for example, with some problematic specimens, or problematic cases, you can alert the microbiology lab if you suspect unusual organisms or testing, and just try as much as possible to send a good quality specimen. Next slide. So sputum is commonly submitted, but it is often problematic. Many specimens are contaminated with saliva full of epithelial cells instead of neutrophils. The samples overgrow, obviously, with oral bacteria, making it difficult to identify the true pathogen. The solution is proper collection and teaching patients how to produce deep specimen, or using induced sputum or bronchoalveolar lavage if needed. Next slide. So this was just the ideal specimens to be sent for respiratory tract specimens. Next slide. For urine, it's the most common specimens we receive, but also one of the most problematic. And for example, bagged urine in children or delays in transport or processing allow bacteria to multiply and leading to overdiagnosis. And we know that we are currently faced with the problem of antimicrobial resistance. So over-treating is not ideal. Next slide. So this was a summary of a study that was recently published, and they wanted because of the problem of overdiagnosis and the emergence of antimicrobial resistant pathogen, they they wanted to there was and we know that there's significant variability in the urinalysis parameters and the thresholds used across different reflex algorithm. But the study, in the end, they noted that using white blood cells on microscopic urinalysis demonstrates the highest diagnostic accuracy, and combining white blood cells with other parameters, for example, a urine dipstick doesn't necessarily improve diagnostic accuracy. And that diagnostic accuracy of using white blood cell remains consistent across all healthcare settings. So even in outpatients and in emergency departments. So the recommendation is to prioritize the white blood cell count as a single screening tool for any reflex algorithms that you may want to implement. Next slide. Next slide, Jeremy.
It's on blood cultures for me. Is it not for you? I think the reception's a bit shaky at the moment.
Oh, okay, now I can see it. Yeah.
Okay, cool. Go ahead.
So with blood cultures, the main issues are, sorry, I was just saying with blood cultures, the main issues are low volume and contamination, and collecting less than 10 millimeters significantly reduces the yield, and using only one set from contamination sometimes, and proper labeling and technique is necessary. So with regards to labeling, as you can see, the level is there, and it shows you where you should fill the blood up until, and in terms of putting your stickers and barcodes, you should avoid putting the sticker above the measurement, because that's where the instrument also reads how much volume is in your blood culture bottle. Is it moving? It's not showing on my side. Okay. For CSFs, fluid must be divided correctly, and you should prioritize your test requests on small volume samples. Typically, one tube is for glucose and one is for protein, again, because the 10 tube for protein goes to biology, and one for microbiology for cell count, culture, and susceptibility testing. Each tube requires at least 2 mL, and additional tests require additional specimens. Microbiology lab immediately after collection, and CSF samples shouldn't be refrigerated.
Cool.
Next slide.
We're breaking up a little bit with you. I presume it's just coming and going. It was fine in the beginning. It's just in the last minute or two. I think we can just keep going, but I don't know if there's anything different that you can do on your side. But if not, don't worry, and let's just proceed, I think.
Okay.
Cool, you can go ahead.
Okay. In terms of the wound swabs, we know that they have poor diagnostic accuracy because they pick up colon tissue samples are far superior. And we can move on to the next slide. Education and training on proper swab collection technique is necessary if a swab cannot be avoidable in order to get a sample that is deep and representative after cleaning the wound, and improve communication between clinicians and the laboratory staff can also help to interpret these samples in a better way. Next slide. So some of the tests, a swab is acceptable, and mostly that's the throat, the conjunctiva, and the nasopharynx, and vaginal and rectal swabs. But mostly you should never send a swab where you can get fluid or pus or tissue. And next slide. So in terms of which swab to use, the calcium arginate swabs can be toxic to viruses and some strains of gonococci. So those swabs should be culture media or transported in non-nutrient media containing charcoal. The cotton tip swabs are not suitable for PCR testing, and the Dacron tip swab, as these facilitate survival of Streptococcus pyogenes. And when you are requesting viral swabs, it's important not to use gel as transport media, and rather use viral transport media or send a dry swab. Next slide. So stool specimens, the diarrheal stool is unformed and takes the shape of the container. For pediatric patients, you may send rectal swabs. And if you cannot get the specimen to the lab within 2 hours, it should be placed in a form stool submitted for C. difficile testing. The lab should not test form stool for C. difficile. And testing without clinical suspicion creates false positive, leading to unnecessary resource utilization and treatment. Next slide. Molecular methods offer high sensitivity and rapid detection, but they also bring new challenges. You can move to the next slide. These challenges include false positives and detection of organisms that may be clinically irrelevant and reduce specificity due to environmental contamination. And we must approach these tests with stewardship in mind. And more testing doesn't always mean better outcomes, and results must be interpreted in the clinical context and use or misuse of these diagnostic platforms. Thanks. So in terms of our job as the microbiology lab, it's not just to produce results, but it's also to help clinicians avoid diagnostic and therapeutic areas. And patient evaluation must include ensuring that the test ordered is appropriate for the clinical scenario. Lab analysis must involve collaboration with the clinician in the lab to ensure actionable and interpretable results. And the benefits of this process include reduced costs for patients, labs, and hospitals, along with better outcomes. And in many cases, errors can be prevented simply by asking whether the issue is the bug, the drug, or the specimen, as it's in the next slide. When you are faced with such a situation like this, which can usually help if you think, is it the right patient? Is it the right test? Is it the right time? Is it the right technique that you are using? And can you ensure proper storage and timely delivery to the laboratory? So the quality of a specimen drives the quality of diagnosis. Most problems are preventable, and attention to detail is very, very important. Specimen management from collection to transport directly influence, and we must really leverage the advantage that we have to be able to collaborate with our multidisciplinary teams. Yeah, thanks.
Cool. I think. Oh, sorry. Thanks. I'm just having a look at the chat. Thanks so much, Sine. Sorry, we struggled a little bit towards the end with the sound, but it was really excellent and really, as you say, perhaps not cutting edge, but really important. This is the day-to-day stuff that everyone gets wrong a lot. Just really briefly, I'm just looking through the chat for any questions. I guess you mentioned earlier in the beginning that clinicians sometimes don't. They will take 5 tests, but they don't know you need actually these go to different labs and you need separate separate tubes for them. That's obviously quite hard. I mean, and some of the clinicians who've been more experienced will start to pick it up. But interns, for example, don't know which tests or don't know which labs. Is there any advice you could give for them for that sort of problem? I mean, do they just send a separate tube for each test, or is there anything we could try and do to help them understand that?
So I think if you go back to the slide with the test.
Hold on, let me just.
The request form. I'm sorry.
Okay, I'll get there. 1 second. There we are. All right, let's go. Well, sorry, we have to go back, but I'll get sorry to for the whiplash. To get back. That one.
It's the request form. I think it was much earlier on.
Not this one currently with the request form.
So also I'm remembering now there's a new update of the lab users manual that's available, but as a general guide, some of these tests are done at different departments. But if you're gonna order a UNE, LFT, CMP, magnesium, total protein, so you'd generally not just send one sample. which
Yeah.
is the yellow top tube. And the different categories mean that it is most likely to be going to a different lab. And the
Okay.
more specialized it is, the more likely it is. But also, you are more than welcome to call your friendly laboratory.
Yes.
Verify.
Charlotte's mentioning in the chat that there was an app for clinicians that might explain what samples to take and volumes and tubes, etc., being developed by NHLS. Do we know anything about that? Is that still happening, or is it fallen by the wayside?
So the app, I'm not sure of, Charlotte, but there is a soft copy of the lab users manual that that I can share.
Yeah, thanks, Jeremy. It was on one of the Echo platforms, and if I'm not mistaken, I think it was being led by hematology in the Western Cape. I think to address exactly what you raised, especially for interns and new clinicians, how much do they take? How many different tubes do they need for the different laboratories, etc. And my understanding at the time is you'd enter what tests you want to order, and then it will tell you exactly what volumes, what tubes, etc., taking into account which different labs it needs to go to. It sounded like a brilliant idea, and I'm not too sure if it's happening still.
Okay. Yeah, that does sound like the solution. I mean, presumably would be locally configured, for like, for example, the Helen Joseph would send off more tests than Charlotte, say, for example. So we get a different answer in some cases. I mean, that is the solution, really. It's hard otherwise, I think. Yeah. Oops, sorry. And then there's another question in the chat about if you receive insufficient specimens, like too many tests, how do you decide which ones to prioritize?
So sometimes where there are pathologists on site, you do see the laboratory, the receiving office staff asking you to call the clinician. But sometimes it really is, especially in the smaller labs, they'd probably do first the ones that they do on site and reject the ones that are sendaways.
Yeah, I guess, yeah. And then things like the rejection rates. I know obviously you keep track of them for the NHLS side. Are those fed to clinicians routinely, or how's that disseminated? Things like overall rejection rates, or perhaps contamination rates for blood cultures and things.
So they are communicated via the lab users meetings. So I think most of the departments have a representative in that meeting, in that committee.
Got it. Okay. Through the lab users committees. Okay. Yeah, fantastic. Thanks. I see a bunch of very positive things in the chat. Thanking you very much. I think it's really useful, this sort of thing, to make sure that we're using the lab optimally and we try and minimize these things. And yeah, thank you very much. There's Salam in the chat who's asked for the slides as well. I don't know if Salam, if you hang on, perhaps Sine can get your email, or you can send it to her as a private message. But thank you very, very much, Sine. Really nice stuff, and good to get this sort of thing and broadcast as far as we can to improve things. It's a difficult environment sometimes, and I think this sort of thing is not done enough. So thank you very, very much.
Thanks for the opportunity.
And Salam has put his email in the chat if you want to send him your slides afterwards.
Okay.
Cool. Thank you, everyone. I'm just going to put the chat, sorry, I beg your pardon, the CPD link one more time in the chat. You don't have to enter it again. If you've entered it once this afternoon, you're covered for both sessions. But if you didn't catch it, or if you've forgotten, or you don't want to scroll up, it's in the chat now. And I'll leave it there for another 20 seconds or so, and then we'll end the recording then. Thanks very much, Sina, and thanks very much to Russell and to Charlotte for a really excellent first half as well. I learned a lot this afternoon, so much appreciated.
Thanks.